Hi, this is Yüksel. I am from Turkey, medical oncologist at Ankara, and we are at International Urological Cancer Symposium, the second one. We had three different cases. The first one was patient with bladder cancer, 66-year-old female, presented with hematuria, and after the staging workup, we had clinical T2 diseases. And for this patient, we decided, because it's just because of the ESMO, and we decided to go with neoadjuvant GEMCIS. And after the fourth cycle of the GEMCIS, radical cystectomy was performed, and we didn't see any downstaging. But of course, we know at least at 1/3 of the patients, when we go to the surgery, we see upstaging. So still the same stage, pathological T2 diseases. And we start to follow up. In less than 1 year later, we see recurrence. Of course, we know most of the recurrence in those patients we see in the first 1-2 years. And the question is now, we have a patient with T2 diseases, muscle invasive bladder cancer. We give her 4 cycles of GEMCIS treatments and then radical cystectomy. And less than 1 year now we have a recurrence. And we try to define which treatment option will be best for her. And of course, we have different options. The first one is EVP, and the second GEMCIS plus Nivo, or chemo, and if you don't have a progress, maintenance avelumab, or second-line treatment. Actually, the first things in most of those trials, we include only patient who recur after 1 year, more than 12 years later. So actually, patient is not the best candidate for those trials, but we are in a border actually. So for these patients, and most of the participants voted in our quiz still for EVP, but we all know for those clinical trials, most of the patients included in the trial have a first-line metastatic diseases, de novo metastatic diseases, or if any adjuvant or perioperative treatment, it should be completed in more than 12 months. But in our poll, we ask our audience, and still most of the audience believe the best treatment option for those patients is continue with EVP. Our second case is metastatic hormone-sensitive prostate cancer with Gleason score 4+3. And we have both conventional imaging, which is the bone scan or CT scan, and in conventional imaging, actually, we stage patient as a low volume disease, but we have a PSMA PET-CT too, but according to PSMA PET-CT, we have a high volume disease. Of course, the first question, we know if we do all tests, there will be discordance because we see more in the PET-CT, but should we treat our patients based on conventional imaging or on the PSMA PET-CT finding? And there is still debate. We have the same debate in APCC too, but actually in the PSMA PET-CT, patient has high volume de novo metastatic diseases. And the second question, what should be next treatment option for those patients? Of course, we do all workup, molecular test, BRCA1, 2, and all HRR mutation, which is not the case for the first line, but maybe in the progressive diseases or in castrate-resistant diseases, if there is any mutation, we will have a PARP inhibitor too. But at this stage, the question is triplet treatments, ADT plus docetaxel or ADT plus RP. Actually, in our poll, again, most of the participants think the best treatment option for this patient is ADT plus docetaxel plus darolutamide, but we know the limitation of those trials, both PEACE-1 and also ARASENS trial, because all trials include the patient with the docetaxel, and there is no third arm, which is we would like. It is like ADT plus RP. So all of this trial shows us that ADT plus docetaxel is like a standard of care, and addition of new hormonal agent improve oncological outcome. But we don't have exact answer whether there is any incremental benefit of addition of docetaxel because we don't have ADT plus RP arm. Actually, what I learned from those trials, if you want to give docetaxel in the first line with patient hormone-sensitive diseases, it should be part of the triplet because we know that ADT plus RP is backbone treatment for those patients. And the only thing we learn from those very important trials, addition of RP to ADT plus docetaxel improve our overall survival. And actually, I agree with our poll, and one of the treatment options for this patient will be ADT plus docetaxel plus ARPI, whether darolutamide or whether the abiraterone, regarding patient comorbidity, drug-drug interaction, and all other things.